More than 46 million of us do not have health insurance, and of those, two-thirds work full-time, approximately 30 million. Another 23% are working part-time, and these are wage-earning Americans who work primarily in service-related jobs, primarily without college education, and so an opportunity to expect a future where they might have a higher-paying job that would provide health insurance is not a part of what they have to look forward to. And the reality is that these are people who simply cannot afford the cost of insuring their health, which leads to another reality, and that is our healthcare system costs, which are out of control, and not just for the individual, but for the economy as a whole. Today, healthcare accounts for almost a fifth of the entire U.S. economy, some $2.4 trillion last year. And by 2018, if we do nothing, that cost is projected to almost double to $4.4 trillion. So we're paying the price of a broken system, and the economy has only made that worse. Since the recession took hold in 2007, there are more than 4.6 million more Americans who are eligible for Medicaid. And as a result, states throughout the country are having to cut back on health programs, as a matter of fact, programs in general, to meet the budget requirements. There's only one state in the country that is not required to balance its budget, that's Vermont. The others have to actually balance their budgets each year. A rule of thumb on this the unemployment challenge is that for every 1% rise in unemployment, there are 1.1 million more Americans who are eligible for Medicaid and 1 million more who are uninsured. And even those who have coverage are suffering. The reality is that even if one has insurance, one is a pink slip, a plant closing away from losing insurance, and the risk of being denied coverage for pre-existing conditions, or even having insurance to find that they have reached their lifetime cap coverage limits and can no longer be treated for serious chronic illnesses. So one of the real paradoxes for American healthcare is that we have the best care in the world, and I believe that. We have the best trained professionals in the world, the best technology, all of that if you can get it. And the reality is we cannot all get it, and that's the tragedy, and that's what we're trying to deal with. And to take a look at how this system is affecting physicians, one of the biggest challenges physicians face is chronic Medicare underpayment. Today, Medicare payments cover only about 51% of a physician's direct practice cost. And because of underpayment, many physicians are forced to limit the number of Medicare patients they see, making it harder for seniors to find a doctor. And when I travel around and go to Washington and talk about this subject, one of the ways I illustrate that is to say that this has become, in my community, a part of the day-to-day conversation. When people gather, they say, can you find a doctor who is still taking Medicare? And I'll talk about that a little more later. Another challenge is that regulatory and administrative burdens have increased year after year. Currently, 10 to 14% of a physician's practice revenue is spent trying just to get paid for the service that we provide. And beyond the revenue losses, there's a misuse of time. What physicians really ought to be about is taking care of patients, of healing the sick, providing cures, and not shuffling papers. And then not to be left out is the cost of defensive medicine every day because of the risk of being sued. Physicians across the country order extra tests and procedures just in case. They're hauled into court and are asked, well, doctor, didn't you imagine under some circumstance that extra test would have been worthwhile? And that defensive medicine cost drives healthcare costs to absurd levels, doing very little to improve patient care or provide quality of care. And I would submit also a system which does not do a good job of providing compensation for those who are ill, who have been injured, and that system is not working. So no matter how you look at it, the system is broken. That's our story, and we're standing by it. I really like his voice. But as we all know, change can be difficult, and this is no exception to that. A quick look at history shows We've been at this actually for about 100 years. In 1912, Teddy Roosevelt made universal coverage part of his presidential campaign. For Teddy, it was a rough ride, and he lost. And it gets worse. 1934, FDR tried to include health system reform as a part of the Social Security Act during the New Deal, and for him it was no deal. In the 1940s, Truman proposed several measures to cover all Americans, and Harry, in his words, got hell for it. Clearly, we are all of a certain age. In the 1950s, employer-sponsored insurance began to dominate the market, and that took the pressure off of any move for comprehensive coverage. By 1958, more than 75% of Americans had private health insurance coverage. That number today is about 52%. Then in the 1960s, after several false starts, President Lyndon Johnson signed the Medicare and Medicaid laws into effect. It was a start, but as we know, it left millions of people under Medicare age who were without insurance. And then in the 1970s, both Presidents Nixon and Carter worked along with Senator Ted Kennedy to try to enact reforms of national health insurance, and they were unsuccessful. And in 1993-94, as the ranks of the uninsured continued to grow, President Clinton began his first term with a renewed effort to provide universal coverage, and that was defeated. In 1997, the Clinton administration did succeed in creating the State Children's Health Insurance Program known as SCHIP, and that provides benefits for millions of youth by covering uninsured children from families who have incomes, but they are modest incomes, but they're too high for them to qualify for Medicaid. So the history of health system reform is not a spectacular story of success. Reminds me a little of that Chinese proverb. When is the best time to plant a tree? The young student asked his teacher, sitting in the hot sun. 20 years ago, replied the teacher. The student, feeling a drop of sweat roll down his cheek, replied, well then, when is the second best time to plant a tree? Now, replied the teacher. And let me suggest that now is the time. We've been out this long enough for this country. Now is the time. The problem will not get better unless something is done about it. And the AMA is in strong support of health system reform. In fact, our code of ethics calls for access to care for all people. And in keeping with that code, in 2007, we responded to the country's insurance crisis by launching a major campaign called Voice for the Uninsured. We reached millions of people through advertising and special events, and that led to 2008 when we helped to bring health system reform to the forefront in the 2008 presidential campaign. And we were with each of the candidates, starting out with the 30 or 100 or however many candidates started out, and then as it was wintered down with a focus to be sure that whoever was elected to office understood that we had a problem that needed to be fixed. And following the election, President Obama made health system reform a priority for his administration. May 11, and that's the picture you see here, he convened a meeting of private and public sector members to discuss the course of health system reform, and the AMA was part of that discussion. The tall gentleman on the left of the table at the end there is Jim Rohack, who is a cardiologist from the Scott and White Clinic in Texas, who is our current president. Now, and even some of our members criticized us for participating too early in the process, but we felt it was important to be part of the dialogue. We believed then and believe now that it's urgent to move a century of debate on health care forward, to repair a broken system and move toward a brighter future for physicians and for patients. The AMA supports health system reform that's based on principles of pluralism, freedom of choice for patients, freedom of practice for physicians, and access for all. And from the outset, our vision of reform has been guided by these 8 principles. First, that all Americans should have access to health insurance, because we know to not have health insurance means to live sicker and die sooner. And second, to have insurance market reforms that would be enacted that would expand a patient's choice of affordable coverage, will eliminate denials for pre-existing conditions, and protect patients from arbitrary caps. And that healthcare decisions must remain in the hands of patients and their physicians, not insurance companies, not government officials, and the right of patients and physicians to contract privately together without penalty should be preserved. And there should be investments and incentives for quality improvement, for prevention, and for wellness initiatives. And the Medicare payment formula that negatively impacts physicians and seniors should be repealed. Medical liability reform should be implemented to reduce the cost of defensive medicine. Insurance claim processing should be streamlined and standardized, reducing both cost and administrative burdens. And finally, that antitrust enforcement policies must be modified to empower physicians to negotiate with health plans to provide increased quality and safety for patients. We believe that together these principles will build a foundation for a stronger, a more equitable, and more cost-effective healthcare system in the United States. And for the last 9 months, the AMA has worked hard to see these principles implemented. We reached out to the nation's leading newsmakers. We lobbied hard in Washington, and we expanded our public outreach efforts, creating actually within our major website, our home website, ama-assn.org. When I forget that, I just Google it. We have a microsite that focuses on all we're doing and everything that we think is pertinent relating to reform, and that's hsreform.org. Now, the road to the White House is a long and winding road, and lots of dead ends and lots of crooks and turns to it, but progress has been made. November 7, the House passed H.R. 3962. It's called the Affordable Health Care for America Act by a vote of 220 to 215, and that frame of reference will help you as you think about the votes that are coming up shortly. The following week, the House passed H.R. 3961, which provided a permanent fix for the flawed Medicare physician payment system in December 24. They really had to get home that night. The Senate passed H.R. 3590, called the Patient Protections and Affordable Care Act. Neither of these pieces of legislation was perfect. There were some things the House got right, some things the Senate got right, and some things they both got an F for. The AMA strategy in this process has been to retain the good in each piece of legislation as we move forward, and to seek to exclude the bad. And that's why we have continued to be engaged, to be a credible voice with those who are actually writing the laws, to persuade them of those realities. And then under that circumstance, the next step would have been for Congress to convene a joint conference committee to reconcile the differences between the bills. A finalized bill would have been then sent back to the House and Senate for approval, and ultimately to the President for signing. Now, then health system reform hit a bump in the road, and actually, let me just tell you that in January there actually was a lot of snow in D.C. I was there. But in any event, what happened was that the election of Republican Scott Brown, January 19, the Democrats lost the 60th vote, which is needed to block a Senate filibuster, and so the efforts of the preceding months were suddenly thrown into question. And so here we are now. And let me just say as an aside, this illustration of the disarticulated skeleton, one of the problems when people talk about doing baby steps to health system reform is that it is all interrelated. It's the knee bone connected to the thigh bone, connected to the hip bone. If you fix one but not the others, you actually may make things worse, and I think that's something we have to think about. But in any event, it was a bump, and so much of the past few weeks of the new year have been, the question is, what's next as far as health system reform? And I would submit, even where we are now on the eve of a potential vote in the House, it is not certain what the future will be, and no one really knows, but at least the path has been chosen. On March the 3rd, after weeks of deliberation and the much televised bipartisan summit February 25th, President Obama made it clear that he favors using the reconciliation process to pass legislation. And without being too wonkish, let me just suggest some observations about what reconciliation is. What is referred to is a process of what's called budgetary reconciliation. And it was originally created to help move budget bills through the Senate chamber more easily. It's a parliamentary tactic that only involves a simple majority, so 50 senators plus the vice president could pass anything. It was based on the assumption that if you're talking about budget matters and you don't want the government to come to a halt, there ought to be an easy way. You shouldn't have the threat of a filibuster regardless of what you're doing. I will say, though, that this whole discussion has, in my mind, given reconciliation a different definition than one would usually think of it. So what would happen then is first the House would approve the Senate bill, the one the Senate passed, Christmas Eve. Next, both the House and Senate would use reconciliation to enact another bill, a handful of relatively modest changes, all budget related, and that's critical. And finally, that package would be sent to President Obama to be signed into law. Now, it's important to recognize, and I think we're already seeing that in the newspapers, that the steps I've just outlined are a best case scenario. The truth is, even with reconciliation, nothing is guaranteed. There are procedural hurdles that must be overcome, not to mention the challenge of gaining a majority support in both the House and the Senate. And remember that House vote back in November, which passed just by a margin of 4 votes. In addition, the reality is the House does not trust the Senate, and vice versa. But I think more on the House side because they really do feel they're in second place in whatever the race is. And even if the reconciliation process is successful, the resulting legislation will leave many important issues unresolved. For example, just to reiterate, the reconciliation process mandates that new provisions need to be directly related to the budget, and that means some important policy issues such as Medicare payment reform, the so-called Independent Payment Advisory Board, quality reporting, Medicare data release are things that cannot be appropriately addressed in a reconciliation bill. As I suspect most of you know, the House yesterday, the House reconciliation bill, which would make these changes, came back from scoring from the Congressional Budget Office, and then allowing for what is standard now, and that's a 72-hour hold. House Democrats are hoping to get the 216 votes necessary for passage by Sunday, and if they do, then the vote will be there. The AMA continues to work, even now, on a daily basis with the administration as well as House and Senate leadership to address outstanding issues of concern to physicians and patients. It continues to be a challenge. So the good news is, based on our current understanding, and I think we understand it reasonably well, of the Senate bill and the reconciliation bill, which just came out, there are a number of things that are consistent with AMA policy and which we support. First is this bill will extend coverage to millions of uninsured Americans, some 32 million, representing 95% of the non-elderly citizens in this country would not cover illegal aliens, and actually this would not even cover legal residents in the country. It would end discrimination against Americans with pre-existing conditions, a rudimentary start at liability reforms, and if you have a question, we can go into that. Raising Medicaid payment rates to improve access to care for vulnerable patients, support for primary care, resources for quality improvement, prevention, and wellness initiatives, resources, color that money to do that. Administrative simplification of insurance claims processing, label that a requirement that insurance companies have to all use the same forms and the same codes and the same edits, so you wouldn't have to learn a new vocabulary each time you had a new insurance company. The not so good side of it is there are significant provisions we do not support, as well as some important measures that have been left out. One of our biggest concerns is a problem that directly affects, and I'm just going to jump to a conclusion, affects the majority of us in the room, and that's the legislation does not resolve the Medicare reimbursement crisis. As I said earlier, chronic Medicare underpayment is an ongoing problem for both physicians and seniors. You can see from this graph, the upper line, and this graph goes from year 2001 to 2016. The upper line is the cost, the increase in cost, basically the inflation rate for caring for patients, and that has risen steadily and inexorably, and we expect that that would continue to be the case. The point that we are now at 2010, where the bottom line drops off suddenly, we're now, the costs, the inflation costs during that period of 9 years have increased to 22% higher than they were. While Medicare payments, which are the lower line, are essentially the same as they were, the same now as they were in 2001. Let me just say, this chart sort of says it all. Since we're in Florida, let me just say it looks sort of like the jaws of an alligator. And apologies to my daughter who went to FSU. We need an alligator chomp. You know, I did that in San Francisco week before last, and there were just about 2 chuckles in the room. It turned out there were 2 people who were from Florida who really understood what I was talking about. The reality is, though, that if the proposed cuts, the 21% cut goes through, April 1, you will see that remarkable drop-off, and there will be followed by future cuts up to 40% by the year 2017. Now, the bill has passed a piece of legislation that would postpone those cuts until October. The House just passed a bill that would postpone the cuts till May. So we now have between now the 19th of March and the 31st of March to get them together on some postponement of some sort. Now, these cuts are the direct result of a complicated payment formula that Congress approved in 1997. It's called the Sustainable Growth Rate Formula. It's been universally viewed as flawed by those on both sides of the aisle, both houses of Congress, as well as the administration, as something that is not working well. It's based in part on the gross domestic product, but it doesn't have factors that help to adjust that. So the result is that year after year, physicians and seniors are threatened with a cut to Medicare reimbursement. Year after year, Congress puts a Band-Aid over the problem. They block the cuts, but they don't fix the real problem. When I talk about this formula and it being related to the gross domestic product, I say, well, you know, my patients, I never had the feeling my patients decided to get ill. Matter of fact, I didn't think they had much choice about whether to get ill, but I didn't think their getting ill had anything to do with whether our gross domestic product was going up or down. So to tie payments to that sort of boggles the mind. Now, to bring that a little closer to home, the AMA has identified Florida as an access care hotspot. We like it hot in Florida. This is not a kind of heat that we can necessarily be proud of. It's a designation that the AMA has given to a collection of 21 states, in addition to Washington, D.C., where access to care for Medicare patients is already at risk. In Florida, there are 15 practicing physicians per 1,000 Medicare patients. That's below the national average. And 15% of the state's residents live in a health professional shortage area. If the cuts go through, this problem will become more pronounced, and as you can see here, Florida just for this year will take a $1.4 billion cut in care that could have gone to take care of seniors under Medicare, and for physicians that's $29,000. And the result, of course, is that physicians would, as small business people, will have to make those gut-wrenching decisions about how many Medicare patients they can continue to have in their practice, or whether they will have to drop out altogether. Now, another area of concern is that the current legislation calls for the creation of what's called an independent payment advisory board. And this would essentially, the creation of this would essentially have a board that would assume responsibility for making payment decisions about Medicare. And it's not clear, and we're working on that, what the authority and the scope of the board would be. Its stated goal would be to reduce the per capita rate of growth in Medicare spending. Our concern is this would subject physicians and Medicare payments to another spending target in addition to the SGR, which is already there. In addition, any recommendations made by this board would automatically become law unless Congress decided to block them. This is analogous to the Base Closing Commission, which we had experience with here in the Orlando area when the training center was a part of that commission. And what it does is it means Congress doesn't have to make hard choices about individual projects. They either vote the whole thing up or down. So the question is, where do we stand? I guess it would be where we sit today. It really is a matter of wait and see. As I said earlier, the president has said, given Congress an April deadline, he first postponed his trip overseas, and now he's canceled it till later in June. And we will know in the next few days, probably by Sunday or maybe longer, whether Speaker Pelosi can get the requisite 216 votes for passage of the Senate bill and the reconciliation bill in the House. If that occurs, the reconciliation bill will go to the Senate, where it will take a 51-vote majority for passage. Now, I think it's important to note, though, that if there are amendments to that bill, amendments come under the filibuster rule, so any amendments to the bill would require 60 votes under the present circumstances, because Republicans are not going to participate in that, for that to pass. So the likelihood of changes in that bill once it gets there are not very great. Now, in the process that's been going forward, the AMA understands that ultimately we may not get everything we want. As a matter of fact, what I've said from the start is that if we get everything we want, we will probably be fairly uncomfortable even with that, because we're talking about big change, but we're talking about a necessary change. The AMA has invested a lot in this process. We're not giving up. We will continue to fight for health system reform that benefits patients and physicians. And let me close by remembering words that President Franklin Delano Roosevelt said under similar kind of circumstances. Here's a man known to, or at least known by and of all of us, whose entire life, including his refusal to be constrained by polio, was a testimony to grit and determination. And what he said was, when you come to the end of your rope, tie a knot and hang on. And once again, thank you so much for this opportunity.
As I said at the beginning, Cecil would like to encourage questions. I think it would be helpful. Dan has a mic that he will come to you, and we want to respect the wordage question, not editorial comment in the speakers. So if you can remember that line, just questions, it would help everybody. And we'll go to this side of the room first, and then we'll come over to this side. Yes, sir. If you give your name before you give your question, please.
In other words, keep it short.
My name is Wilfred Madsen, and my question is, what function does the insurance industry provide?
What function?
Yeah, well, I think people have, and the question is, what function do insurance companies provide? And people have, that's a question that's asked a lot, and it's particularly asked in the last few weeks when we've seen these double-digit increases in premiums, and the wonder is where that money is going, and what does it reflect more than going to the bottom line and stockholders. And of course, I suspect most of us in this room are stockholders. But the reality is that insurance, particularly for health insurance, began over 100 years ago, or slightly less, and became more pronounced, I would say, during World War II and afterwards. And that was the point at which we actually got to a point where for medical care we could do things. Prior to that, back in the late 30s, early 40s. It was penicillin and sulfur, our first real antibiotics. Prior to that, medical care was to a great extent holding someone's hand and being sympathetic and doing fairly simple things. So the point at which we could do more, the cost of care went up. The cost of being in hospitals went up. And so increasingly people were unable to, out of their pockets, take money to pay for hospital, to pay for operations. And so that was the purpose of insurance early on, to insure against that, to put a premium in on a monthly basis. And then more recently, over the past several decades, the cost of other health care, and that is medications and treatments, has also reached those kind of proportions. So for the average person, covering those things out of their pockets has been impossible. So that's the function that insurance serves. Clearly, we need to be sure that that function is done well, and they need regulation to help with that. And there's a lot of egregious kinds of abuses related, but that's the purpose they serve.
In fairness, sir, the gentleman over here had his hand up first. So, Dan, if you give him the mic, and then we'll come to you, okay?
Matter of logistics here, it's easier to cover them on one side of the room so we don't waste time going between.
Whatever happened to the public option, and how does the AMA stand on that issue?
Sure. What happened to the public option? The question is, what happened to the public option? The answer is the public option went away. As I suspect some of you know, the House felt very strongly that a public option was needed, and that resulted in the real furor with town hall meetings during last summer and fall when that was on the plate. And I think the American people said very loudly and very clearly they were not comfortable with that. They were concerned that that public option, meaning one of the choices people would have would be a government-run insurance. It wouldn't take it all over, but it would be competition for private plans, that would be what would be on the table. And I think Congress heard that loud and clear. The Senate bill did not have the public option in that. And we have, and we know Speaker Pelosi has said very publicly she's not going to fight for that. So there are many people still in the country, apropos of the question about insurance companies, who say there's been so much consolidation of insurance companies in this country that competition in a marketplace is difficult to have, and there needs to be that competition. That's the rationale for it. But the answer is it's off the table. It's not in the Senate bill, and that's what's going to be considered. It will not be part of the reconciliation bill, and I think it is highly unlikely that that will ever appear with the current legislation.
My name is Don Kane. After more than 50 years in marketing and sales, I can't think of a single time when someone wanted me to hurry up that it would have been to my advantage to do so. I don't hear anything about personal responsibility on the side of the receiving end. Is there some point at which a recipient can disqualify himself? For example, if he uses 2 packs of cigarettes a day, or maybe 2 6-packs a day, or maybe he engages in unprotected sex. Is there something where he can disqualify himself? If he owns 2 color TVs or 2 cell phones, or if he's making too many car payments, is there some point at which this person who can't buy their own health care no longer qualifies for the taxpayers providing it?
Well, thank you. As you extended that list, I think you covered most of it. But that's an important point, and I think it gets to the question of cost of healthcare in this country, and there are multiple factors that have to do with cost. Part of them have to do with technology and advances, kind of good things that we know are very helpful. There are other things that need to be controlled, and the whole area of health behaviors is a critical part of that. As a matter of fact, if you look at the determinants of health for a population in America, only 10% has to do, the determinant of health, whether you're healthy or not, only about 10% has to do with your access to care. 20% has to do with the parents you chose or who chose you. We're working on choosing our parents. And another 20% has to do with the environment, so clean air, clean water. So that leaves 50% of the determinants of the health of the population have to do with things we do to ourselves, so cigarette smoking, alcohol abuse, obesity, sedentary lifestyle. And so we have to address those as a part of any meaningful health system reform. And the answer is the list that I just described. There are funds to start approaching that problem, to look at initiatives to deal with quality and with health behaviors. The issue that you raise, and that is how do we provide incentives for people to do those things, is a question of whether you provide the carrot or the stick. You know, we have a long way to go on that as well as making that happen.
I
So,
appeal to
Dan,
common
there's
sense.
two questioners in the back of you. Please let
I
other
appeal to
speakers
common
speak.
sense. Let's don't rush into it.
Yeah. Well, 100 years is not rushing real fast.
Hi, Cecil.
Remy.
Clearly, one of the biggest challenges, you know, in this effort to reform the current health system is controlling the costs. You mentioned the fact, you know, that in a few years, the cost of healthcare will balloon to over $4 trillion. Casting aside, you know, the giddy atmosphere that we saw with the Democrats 2 days ago when the CBO scored the cost of this bill in adding 32 million people more to the rolls at $940 billion. You know, this bill would require 500 billion cuts from Medicare. It would require 500 billion in new taxes, and it also would require 300 billion picks for what you said before, the doctor picks. The
Do you have a question, sir?
Yes, sir. Considering what we know about Medicare, Medicaid, and Social Security, do you believe that these projections by the CBO are credible? And the second question is, why does President Obama think that Medicare is going to be strengthened when $500 billion is going to be gutted from the program?
Okay, thank you, Remy, and those are actually a number of questions. Let me just address Medicare because I think that's an important issue, and this is an area where there's some, let me be kind and say, demagoguery that goes on. The numbers that everyone looks at and that you've accurately described include probably close to $300 billion, which has to do with phasing out Medicare Advantage. Now, let me just, and that's something we support. The reality is that Medicare Advantage, which is the Medicare HMO program, as opposed to regular Medicare, those plans are given 14% more for providing care than for regular Medicare. So that what that means is that if I'm on regular Medicare and you're on Medicare Advantage, the government pays $14 more for every 100 for your care. We think that's a fairness issue, and so the biggest part of those funds has to do with phasing that out over a number of years so that everyone has the same amount paid by the government for that care. Another significant part of that, something less than $200 billion, represents decreases in costs, decreases in payments to hospitals, because at the present time, hospitals who provide care for the uninsured give what they call disproportionate share payments. They get disproportionate share payments from the Medicare program to make up for their losses of providing coverage for the uninsured. Everyone's going to be, or most everyone's going to be insured now, and so they have actually on their own have agreed that they will no longer need those funds. So it's not a totally fair observation to talk about that. The reality about Medicare being cut in that way, the reality is Medicare benefits will not change. The things that people get for Medicare will not be any different, will not be any less. And maybe, I guess maybe the other thing is to talk about Medicaid, because this legislation does provide an increase in eligibility for Medicaid, either depending on where we are, 133% of the federal poverty line, up to 150%. So there will be more people covered under Medicaid. And so the question is, well, states are already having problems with their budgets related to that. And so this legislation will provide, at least for the early part of this phase-in, that the federal government will cover all the cost of that increased number of Medicaid patients who are covered. And then after, I guess, 4 or 5 years, they will cover like 90% of the cost. As you know, at the present time, Medicaid is a federal-state program where there's a match between state and the federal government. It's either 60-40 or 50-50, depending on the state. And so funds have been put in to try to ease the problems that would be associated that states would have with their budgets related to this ramp-up expansion of Medicaid. The other thing that Congress has done in this legislation is to provide $50 billion, which is actually, even in the years of trillions, is still a significant hunk of change, which would go to increase payments to primary care physicians taking care of Medicaid patients up to 100% of the Medicare payment rates. Hopefully a help, because right now many physicians just filing for Medicaid doesn't make much sense. And maybe I'll just stop with that. Very important questions, Remy, and thank you for those.
Mariana LaRue, does the current health bill before Congress include the $250,000 non-economic cap on malpractice penalties, and or what is non-economic cap, and or what is going on regarding medical liability reform?
Thank you, Mariana. And we believe, as I indicated, that that is an important principle for health system reform, and that the kind of limits, the kind of reform that you've described, and that's which came out of California, the so-called MICRA law back now some 30 years ago, which put limits on non-economic damages and caps on contingency fees. We know that that legislation helps to control the rise in liability premiums for physicians. That's worked in California and Texas and Louisiana and actually here in Florida and a number of states. And so we know that that works, and that still is a goal for the AMA. The reality of that is that even when we had a Republican president and Republicans controlling both houses of Congress, we were not able to make that happen. You can imagine, and matter of fact, the president has told us when he met with us last June that that's not something he's going to support. We will continue to work on that. I think maybe so the answer is those kind of reforms for medical liability are not in the legislation. They should be, but they're not. The other answer is that as time has gone on, we have realized that just putting the caps in a way, it staunches the flow of blood, if you will. What it does is keeps premiums from going higher, and so physicians will choose a state where those caps are in place. Has done nothing for defensive medicine. Physicians, regardless of their premium, are still just as afraid of being sued. 60% of the time cases are brought, they are dropped, and of those that are not dropped, 90% of them are found to be non-meritorious, and yet the physician had to go through a multi-year experience of being involved. So we have been looking over the past several years at saying we've really got to change the whole system. We've got to have a tort system, and even my son, the lawyer, will tell you that that system does not do a good job of, in an expeditious way, recognizing injury and damage and compensating it. And when my son is successful, even then there's multiple appeals and years before the patient receives compensation, and we think patients should receive compensation. But in the meantime, physicians are brought into court, and so we believe that you need to change the whole system so that people are not afraid if they give a certain kind of treatment, they're going to be called into court. So there are a number of things that are being looked at. Administrative determination of damages, medical courts related to a determination of guilt or innocence, so-called safe harbors, where if a physician is practicing according to certain scientifically based guidelines, they will have presumed to have practiced good medicine, and if they're brought to court, they can use that as a part of the defense and other things like expert witnesses. So we think that ultimately is, if we look back on this, we'll say, that's what made a difference, which gets us to where we are. The president on his own several months ago actually put forward $25 million to look at pilot projects of those kinds of things around the country. The AMA is working with 8 or 9 states now that are already putting in bids for those pilot projects to see if these ideas about reform make sense. The Senate bill, which will be going forward, has an additional $50 million to look at that to see if these are things we ought to study. And just finally, non-economic damages are damages that you cannot measure. They're the so-called pain and suffering damages. So none of this would be intended to limit payments of medical care, of rehabilitation, of lost wages, all the things one can count that are part of the injury that occurs under those circumstances. And we actually think that quote, pain and suffering, there is a value there, but there ought to be reasonable limits, and hence the caps on non-economic damages. Thank you.
My name is Foster Levy.
Yes,
Since congressmen and senators are human beings also, and they have health care, what is their philosophy in regard to what they're doing now in regard to this bill when they go to their doctors? And I'm very concerned about Medicare payment to the doctors because, as you may know, money is the root of all evil. And if physicians do not get properly paid, what kind of service can we expect even though they take these Hippocratic oaths?
And due to the time limit, we want to thank Cecil for
Okay.
his appearance here tonight, this afternoon.
It's been that long. Let me first respond to your last statement that the Hippocratic Oath is an important part of the profession, and regardless of what the physician is paid, you can count on that being a part of how the physician approaches that. My experience in this community over many years now, and I sort of say it this way, I think physicians get up in the morning wanting to go out and do good. Physicians want to provide the best care they can to their patients, and if they have the tools and the information and the knowledge, that's exactly what they're going to do. But the question about payment is critical because what won't happen is a change in the quality of care. What will happen is a loss of the care. And so physicians who have to pay salaries and to keep the lights on and to buy new equipment and replace old equipment and make provisions about the future in terms of what I need to invest in, like electronic health records, which we think have value. And then they look at a Medicare system which is now unreliable because for the last 9 years, payments have been flat, and that just won't work at some level. And so they'll have to make, as I indicated earlier, gut-wrenching decisions about what percentage of their practice can continue to be Medicare patients. And that's why I would call those senators in particular and congressmen and women and to say this has to be fixed. This is critical not only for this group of people, some 40 million who are on Medicare, but it's also critical for the country because we can't reform a health care system when the government programs that we already have are falling apart. And that's why there is a focus on Medicare as well as Medicaid in this legislation. The whole is the Medicare payment that we're dealing with. And once again, thank you so much for this opportunity.
Cecil, thank you with your tight schedule. He will be in session with the legislators this afternoon. He tells me, thank you for coming.